Professor Dr. Srikant sir will start our session with asking few questions, and later on his lecture will be shown, and again we'll ask few questions, and we'll ask the seniors to share their experiences in this topic. So I request Dr. Srikant sir to ask few questions to PGs.
Yeah, the first question, good evening, is can anyone name the two signs of acute suppurative tenosynovitis of the finger? Any two signs of acute suppurative tenosynovitis?
Only 1 minute will be given. If nobody answers, we'll go to the second question. And you yourself will answer these questions at the end of the lecture.
So the second question, if no
Fusiform
one is,
swelling, sir.
yeah,
Anybody would like to answer? Thiru?
Fusiform swelling, sir. Canavel sign.
Yes, fusiform swelling. Yes, one sign. What is the other sign?
The digit is flexed, tenderness.
Held in flexion.
So,
the held
tendon,
infection.
flexor deformity, and fusiform swelling. One more you tell.
Tenderness on palpation.
Tenderness
Is it
where?
palpation? Where?
On palpating in the region of tendon sheath.
Palmar aspect.
Wonderful.
Yes,
Correct. On tendon sheet, and one more you should tell in specific it is. Is the same thing
Pain
will be
on passive
there?
extension.
Yeah, correct. So all these four signs together called what?
Canavel's
Name.
cardinal sign.
Yes, good. Sir,
Yeah, the second
full
question
marks.
is, we can, the lecture also talks about this. So, which abscess commonly manifests as a collar stud abscess in the hand? Which acute infection of the hand can manifest as a collar stud abscess?
TB, sir.
Be loud, please.
Thiru, be a little bit loud.
Sir, TB.
What is PB?
No.
He's telling sir TB, tuberculosis he's telling.
No, it's not.
No.
No. Sir is asking in specific. There are various
Which?
abscess in the palm.
Palm,
Which
okay.
abscess is
Commonly
Which small way?
manifest as a collar stud abscess.
collar stud? It presents like a collar stud. Why it is called collar stud?
Anyone can respond.
Anybody?
Yeah.
Any
It's like-
PG?
In
What is
the-
collar stud abscess? And which
Yes,
abscess
Rishika.
will present like that? What
Yes,
is the
Rishika,
meaning of
you were-
collar stud?
In the region of web space.
Yes.
Yes, good. Why
A
it
web
is called
space.
collar stud? Why it is called collar stud?
Anyone can answer. The same
Anybody?
person who said tuberculosis, he should be knowing what is a collar stud abscess.
Sir, connecting to communication, sir. Or
So two cavities,
two
abscess cavities connected by a narrow. Yes, stop. Yes.
Okay, just one more
Right.
question before we go to the lecture. Normally, when you operate on the hand, you use a tourniquet after exsanguination of the hand or the forearm. So, what are those conditions in which exsanguination is contraindicated?
Infection, fellow.
Infection,
What is the other one?
Malignancies.
malignancies,
Yes.
yes.
What else?
Doubtful vascularity.
Doubtful vascularity. Anyone else?
Somebody else can respond also.
Yes.
Ischemic condition.
No problem.
Ischemia. Okay.
In ischemic conditions, do you apply tourniquet?
No, ma'am.
No, ma'am.
Okay, you usually don't apply tourniquet. Okay, cellulitis and infection, some necrosis. So in those conditions, you don't want the toxins or the infection go into the systemic circulation. That's why you don't exsanguinate, right? Any other reason, sir?
No, that same reason.
Yes. So all the
All this will
conditions
be
which will
more cleared.
make the local infection or the necrotic toxins make entry into the systemic circulation, you should not do. Okay. So that's why you don't exsanguinate. Sir, shall we
All this will
proceed to the
become more
lecture?
clear in the all this will become
Yeah.
more clear in the upcoming lecture also.
Yeah.
Any more questions, sir?
Any
No,
more
that's
questions,
all.
sir?
That's all.
Okay. Janaki Ram, you can start the video.
Yeah, yes, ma'am.
Good evening. I'm going to talk to you about infections in the upper extremity. Now, wherever be the infection in the hand, the edema that manifests is usually in the dorsum because of the loose nature of the subcutaneous tissue there, and the edema may not be apparent at the palmar surface of the hand, even though that's the primary site of infection. Infections in the hand can be acute or chronic. They can be superficial or deep. They can be typical or atypical based on the kind of organism that causes the infection. They can present to us early or late. Now we have here an infection, as you see here, and you can see here. This is a delayed presentation of an infection, and as you can see in the image below, the epitrochlear lymph nodes were also enlarged. So the primary site of the infection here is an injury due to a thorn prick causing an infection in the dorsum that is trapped into the wet space and spread proximally also to involve the epitrochlear lymph nodes. This is a classical late presentation. Infections in the hand usually manifest as pain. The swelling, as I said earlier, would be mainly in the dorsum of the hand unless the patient has had received some antibiotics and inadequate treatment, where the swelling can manifest on the palmar surface of the hand also. There will be exquisite tenderness and fluctuation on account of the thick nature of the glabrous skin may not be apparent except in very late presentations. So the basis of all is a clinical diagnosis. One does need to do an X-ray also to rule out the presence of foreign body, which may be the presuppositing cause, and an ultrasound may be recommended for chronic infections or infections that are very deep, so that they can be localized to one of the palmar spaces. Most of these infections are usually local, but they can be hematogenous, especially in the setting of immunosuppression. The questions that we need to answer, having made a diagnosis of an infection in the hand, is: does it require drainage? What is the anesthesia or analgesia? What surgical approach? Do we have to do anything beyond drainage? And the aftercare of this patient. We'll start with the aftercare. It is traditionally a cuff and collar that is given for limb elevation, but it is not a good choice because there may be a constricting effect at the wrist if it's not properly applied. And probably it would be more prudent to use an old-fashioned triangular bandage, or sometimes you can do a hand elevation just by incorporating the forearm and the elbow in a pouch, so that the elevation can prevent edema formation and earlier resolution once the surgical treatment has been complete. So either a triangular bandage or a pouch and elevation, which is probably hung up to an IV stand. First is the simplest of the lot, is a pulp abscess which happens distal to the terminal digital crease. Swelling may be apparent, may not be apparent, but typically patients present with pain that increases with dependency, and there is an inability to sleep at night. The patients complain of a throbbing pain or a pin-pricking kind of a pain. That itself is enough to diagnose. Initially, antibiotics would be given unless you have a reason to suspect that the antibiotics are not working or the patient is not improving as far as the symptoms are concerned, in which case surgical drainage needs to be done. Now, where there is a fluctuation, as can be seen in these two cases, a direct approach can be given by incising the palmar skin. We all know that it is not desirable to have a scar running along the contact surface of the digits. So, where there is no fluctuation, indirect approach through a midlateral on either side or just a midlateral, not even reaching up to the tip of the finger, can be used. And the release here, one has to remember, because the dermis is very thick, you make sure that you penetrate the dermis and only then would the abscess drain out. And the thick fibrous septa would mean that an artery forceps or a hemostat has to be passed in to completely separate the fibrous septa that will permit proper drainage. Now, this name is something one needs to know because he was probably the first person who described what is called suppurative tenosynovitis. And the clinical symptomatology goes by the cardinal signs of Cannibal. There will be an exquisite tenderness over the proximal portion of the flexor sheath. There will be a sausage shaped or fusiform swelling of the entire digit. The affected finger will be held in a slightly flexed posture, and probably the earliest manifestation would be that there will be exquisite pain when you try to extend the finger passively. And the slight flexion on the tip, the location of the tenderness, and the pain on passive extension clinches the diagnosis of a suppurative tenosynovitis. If they present early, there are two ways that you can treat them. There will be a proximal incision to identify the proximal end of the fibrous flexor sheath and a midlateral incision also. And the drainage will be done by both this incision and that incision. And during the surgery, a small feeding tube can be inserted to irrigate that wound copiously before this is sutured. Another elegant method is to avoid this midlateral incision and just have a proximal incision and a distal incision through which a feeding tube is inserted, and this continuous irrigation for 48 hours till the culture reports are available so that the antibiotics can be changed, can be used in very early cases where you know that only irrigation through these access incisions is enough without any formal surgical drainage. But you could have situations where the patient presents very late, as for example, the entire finger is swollen and we can find subepidermal abscess here. So it makes sense to open up the whole digit and drain completely. Otherwise, the flexor tendon can necrose and slough out. This can be followed by the same technique described earlier, where you close it over a drain in the form of a Penrose tube or a feeding catheter, so that post-op irrigation will, with antibiotics if necessary, will cause earlier resolution of the symptoms. An abscess can also occur in the web space. Typically, they have dorsal edema and the digits are separated from each other. It could be part of a collar stud abscess, meaning there could be an abscess which is close to the dorsum and it has penetrated here to manifest on the palmar surface of the hand. So there are various incisions that can be used. none is more advantageous than the other. It can be an oblique incision in the form of a Z, then a transverse incision, and a counter incision on the dorsum of the hand may also be required to ensure that the collar stud component is taken care of. This is a web space abscess. We also have a condition which is called as human bite injury. Typically, the knuckles are injured, and this is very unique in the sense that as soon as the digit extends, you will find that there is no correspondence between the penetration of the skin and penetration of the capsule. So invariably, this whole thing gets closed up, and whatever organisms are allowed to sequestrate here. So this is a surgical emergency. The common agents are Staphylococcus aureus, Streptococcus, and a specific organism called Eikenella corrodens. It requires surgical toilet and laying open of the wound in addition to the antibiotics for systemic control. Now, this is a human bite injury, which is considered to be a surgical emergency on par with an abscess that needs to be drained. Now, typically, when an abscess is drained, we send the abscess fluid for gram stain and culture. If you don't find much in the way of pus, but you find that there's fluid there, which you have drained because you have gone in a bit more early, or because the patient has already been put on antibiotics, then the specimen or tissue should be divided into two parts. One is sent for histopathology, and the second half is sent as two separate containers. The first one is for gram stain, AFP stain, and a potassium hydroxide for fungi, and the three remaining are sent for aerobic, anaerobic bacteria, mycobacteria. Why we need to be careful about this, except for the most routine case of an abscess, say a pulp abscess, more proximal infections can be mixed, that is one, and tuberculosis or leprosy is frequently a surprising agent. It's better to be careful and make sure that, especially in the setting of immunosuppression, better to send multiple specimens that cover the entire spectrum of bacteria, fungus, and acid-fast bacilli. This was a case where the patient has substantial swelling in the dorsum as seen in the first image, but the problem was mainly in this region. Even the thumb is swollen a bit, and the swelling in the thinner area can be appreciated with pain and tenderness in the palm. Because this was a deep-seated abscess, an ultrasound had also been done, which showed loculated collection in both the thenar space and the mid-palmar space. So which needed two incisions. One is a thinner kind of an incision, which allowed us to drain not only the thenar space, but also the mid-palmar space. And the second one, because the patient had forearm swelling, what is called the space of Parona, by going ulnar to the FDP and going directly onto the pronative water test. Because these infections, because of the presence of bursa, which communicates with the distal forearm, can cause an infection. This was not a Staphylococcus aureus, but a streptococcal type of an infection. So there was not much in the way of pus, but there was dirty fluid which was sent for culture. Now, this is a cross-section that tells us what is the mid-palmar space, deep to all the flexor tendons, and the thinner space, and a single incision can be used to drain both of them. Now, these are deep space infections, and here there is a role of ultrasound for the diagnosis. So, mid-palmar space infections, there are multiple incisions that can be used, and one does need to remember the incisions need to be done in such a way that we don't damage any longitudinal neurovascular bundle-like structures. So the safest would probably be this kind of an incision or this kind of an incision. And if it is more distal in the mid-palmar space, a distal longitudinal incision can be given. For a thinner space incision, this is the best, but sometimes one may have to give a counter incision on the dorsum, either transverse or longitudinal, to tackle the cholesterol part of the abscess. This is a diagram to show that the connection between the synovial sheaths of the digits and the thumb is variable, but the commonly seen pattern is this, where both the little and the thumb communicate with each other. That is the radial and the ulnar bursa. And the next common one is where you have only the communication with this. The fingers are all separate. And in this case, the flexor tenosynovitis would not spread to this bursa, but this bursa again can burst, leading to infection in the space of corona, which is in the distal forearm. Hence the need in advanced cases of making sure that the distal forearm is also drained through a separate ulnar forearm incision. One can have atypical and chronic infections also, because these are surgical curiosities, and the offending agents are usually mycobacterium, atypical mycobacterium, fungal conditions like aspergillosis and mucormycosis. Actinomycosis is also a possibility. It's a bacterial infection, but it gives rise to a severe chronic kind of an infection. Other rare fungal infections can occur in the upper extremity, but they are usually related to particular occupation, travel to an area where such infections are endemic, and systemic immunosuppression. Patients on chemotherapy, patients with tumors, or patients who have received a transplant and are on immunosuppressive agents. Tuberculous infection of the upper limb are not very uncommon, because it is still not controlled in our country, and there could be different ways of manifesting a cutaneous nodule, which is usually implanted in hospital workers. You could have a tenosynovial tuberculosis, one of which is called a compound Palmer ganglion, and rarely may be a cause of a carpal tunnel syndrome. One can also have tuberculous bursitis or arthritis or osteomyelitis. So the last two invariably involve the joint and the bone. So all these manifestations are possible in case of a tuberculous chronic infection in the upper limb. So whenever you have a doubt and you're dealing with an infection, it is best to, follow the rule that biopsy what you culture and culture what you biopsy. I have already told you that the samples are sent in two separate formalin and saline, so that the culture and the biopsy can mutually help in diagnosis. Before we end, are these surgeries done with the tourniquet? Definitely yes. At least the deep infections need to be done with a tourniquet, and preferably even the superficial infections also. Exsanguination is not done. This should be not done with a local infiltration. Always a suitable nerve block should be chosen. It can be a digital block, it can be a wrist block, it can be a block, but certainly no infiltration. Sometimes the stab technique doesn't work, especially for delayed presentation of suppurative tenosynovitis, where a formal midlateral volar zigzag incision is required to make sure that the drainage is complete. And finally, we stain, we culture, and we do a biopsy. Thank you.
Thank you, Srikant sir. Wonderful lecture. Sir, one question I'll ask.
Yeah.
So, the irrigation or opening up, whatever it is, tenosynovitis, like a tendon sheath.
Yes.
So, do you release the entire the police?
No. See, the case that I showed was basically an advanced case.
Yeah.
In a diabetic, there it was necessary to open the whole finger.
Yes, sir.
And it is better not to do it if you get it early, because then
Okay.
you are trying to make the condition worse. Only
Yes,
thing
sir.
is, we have to identify that there's a tenosynovial infection, and whatever incision is given should access the synovial sheath. And
So, I want the PGs to have the clarity where they have to keep the tube.
the tube has to be
So,
within the synovial sheath.
yes.
And
So they
because,
have to
and it,
pass in between the tendon and the pulleys, isn't it?
yes,
sir?
yes.
Yes. So it should be very clear. When you open up also, you will try to spare a part of A2 and A4 pulley, and rest of it you can incise. And when it is in early period, they present, when you are giving incision at proximal and distal, you see that the incision will incise the skin, subcutaneous tissue, and the pulley, and the tube should be inserted through
No,
the pulley, isn't it,
yeah,
sir?
no,
Yeah.
actually, we should not be saying pulley, we should be saying the fibrous flexor sheath is entered.
Yes, sir.
And if in the
Fibrous flexure
proximal
sheath.
incision,
Yeah.
once we open the fibrous flexor sheath, we will be
Yeah.
somewhere in the vicinity of the palmar aponeurotic pulley. So if you make a stab incision there in the
Okay.
proximal, in the palm,
From, yes.
so
In the
then it should
palm, you
not be a
will,
problem.
yes. And through that, the tube should be inserted and pushed up
Pushed up, right up till
into
the
the,
LDP insertion.
yes, yes.
If it is possible to get it out through a counterization distally, that also should be done, because then whatever you
Yeah,
are pushing from here comes out from the other side
yes.
and does
Otherwise,
not
we
stay
have
back.
to put another tube
Another tube.
for irrigation.
Yeah.
Yes. It's very clear, sir. So we'll invite Dr. Bajaj sir to share his experiences.
Is he there?
Bajaj sir?
I don't think he is there,
He's not there, sir.
but Dr. Umar Farooq is here, I think.
Yeah, I'm listening
Earlier
to
he
each
was
and every
there.
word. Yeah.
Yeah, Umar, would you like to share? Sir also there. SP Bajaj sir.
Okay.
Sir has joined, but maybe he is not there. Maybe
Okay,
sometimes the call comes or
you
like
would
that.
like to share anything, your
Sir has,
practical
I think Sir has
experiences
not missed.
before we start asking the
Sir has not
questions,
missed anything. I think Sir
before,
has covered almost everything
yeah,
which
yeah,
comes to my
yeah,
mind. Bajaj Sir is
yes,
there.
yes,
Bajaj Sir.
yes. Bajaj sir is there. Mhm.
Yeah. Now he is.
Any senior faculty in attendees would like to share their experiences, practical experiences? They can unmute and share their,
Coming to the infections, one thing come to my mind. Few years back, we saw a
yeah,
few cases of the sarcoidosis also. The animal, these infections coming,
yes, yes,
especially in
yes,
the rural areas when they deal with the animals.
yeah,
So I could not properly remember. First, it was diagnosed that they were the diagnostic dilemma. First, they were saying it is a tuberculosis. Then biopsy was taken. Ultimately, it came out to be sarcoid, if I remember correctly. Few years back, it was also reported by medicine people. They had called us also. So they were first suspecting tuberculosis.
yes.
But when they took the biopsy, they examined, then they could found a sarcoid there, and they started the treatment, and it responded.
Mm.
This came to my mind just
Yeah,
for the knowledge.
that is
Yes,
true. Anything that
Yes, sir.
is presenting as a chronic infection, typically that patient
Right.
would have visited multiple OPs, would have gone to multiple consultants. In such
Yes,
a
sir. Yes, sir.
situation, biopsy is the best way to prove.
Yes,
yes.
sir. Yes, sir.
The one
Yes,
thing
sir.
is difference between the acute and chronic. The pain will not be there, and we should keep always the diagnosis of the tuberculosis and other conditions to
Yeah.
rule out. And biopsy is the best way. Yes.
Yes, yes.
Dr.
One of
P.V. Sudhakar sir is also there in attendees.
Yeah, ma'am,
Sudhakar.
one other point,
Yes, sir.
though not in the hand, in the upper extremity, you can have the cold abscess, which is caused by Hansen's.
Yes, sir.
I
Yeah.
have seen it
Near the elbow.
near the elbow, sometimes in the arm. You can have something that is an abscess without any inflammatory signs.
Yes, sir.
And again, there, culture or staining
Yeah.
for acid-fast bacillus along with the biopsy will prove the diagnosis.
Yes, sir. But they will present with the claw hand also, isn't it, sir?
Not sometimes, yes, but not always.
Oh.
Not always.
50% maybe
But they,
presenting with the claw hand,
but they
features
may
of
be
the claw
having
hand.
symptoms referable to the ulnar nerve, usually sensory kind of symptoms.
Yeah, yeah. But sight and all always we should suspect.
Yeah.
Yes. Sudhakar sir?
Yeah, Lakshmi, sorry, I joined a little late. I'm just listening to you all. Please go ahead.
Sir, we are discussing about the hand infections. Anything practical aspects you would like to share with your
Not immediately,
experience?
but yeah, let it keep going. We will share a little later. Let us.
Okay, okay, sir. So, shall we start asking questions to PGs?
Yes, in
Srikanth
between
sir,
we
you
can
want to
also add
continue? I
later on.
have rapid fire like questions I will ask. So, you would like to ask anything before that?
No, ma'am, you can ask.
Okay. PGs, are you ready? Please say
Yes, ma'am.
yes.
How many PGs
Yes,
are
ma'am.
there?
Yes,
How many
ma'am.
PGs
There are
are there?
many,
4, 5?
many are there.
That is great.
But I have
You have
very few
not to
questions
worry.
only.
Nothing. Their
No,
biggest
they
thing
can
can happen.
answer,
Answer
Umar, no
can be
problem.
wrong. Please don't
No.
shy. Don't
All
shy.
these are
No, I'm
just
telling you.
from the lecture. Don't worry at all. Okay.
Yeah.
Yeah. So from the beginning, in the same order I'm asking. So start bombarding me. So what is the common site of the swelling in the hand when there is infection?
Dorsum of the hand, ma'am.
Very good. Other than dorsum, where will be the swelling? Any hand infection, dorsum swelling will be there, but in specific,
Species, ma'am.
Both
in
fingers.
specific, where will be the swelling? It is common. Uniform swelling will be there for all the types of infections on the dorsum. What is the cause? What is the cause?
Loose areolar tissue.
Loose areolar tissue. How many spaces are there in the hand? How many spaces are there in the hand?
Five
No,
spaces, ma'am.
at least tell the names.
Timings matches. Timings
The
matches.
dorsal space is
Pardon?
palmar space. The dorsal
Yes,
space, the palmar
subcutaneous.
space, we have in palmar
Who
space we
is
have the thenar
answering? Please
space.
don't.
Please, no side talks. Please mute yourself. Only the students will keep it on.
Mute everyone. Everyone mute other than who answers.
All the attendees are requested to please mute yourself. Only the PGs will keep their microphones
Only the
on.
answering PG should unmute. There
Yeah.
are how many spaces? Name them.
Yes, ma'am. We have the dorsal space. We have in palmar
Dorsal
space we
what
have
space? What space?
subaponeurotic space and subcutaneous
Ye-
space, ma'am,
Yes, subcutaneous space.
and
Next,
subaponeurotic space
where subaponeurotic?
in
Is
dorsal
it
only, ma'am.
dorsal or palm?
In dorsal, we have subcutaneous and subaponeurotic space also, ma'am.
Yes, very good.
In palmar space, we have the thenar space, we have the mid palmar space, we have the hypothenar space, and the interdigital web spaces, ma'am.
Yes. So, what is phelon? Some other PG?
It's an infection in the pulp space, ma'am.
Same, Ramya?
Yes, ma'am.
Okay. So, what is the importance of the pulp space? Some other PG? Any other PG? What is the importance or the important feature of the pulp space? Ramya? Hello?
There are multiple septa which run.
Yes, yes, yes. Tell. Who is that? Yeah, please tell.
There are multiple septas in distal distal 2/3 of distal phalanx in the pulp space.
Septa where?
Longitude.
Extending from where to where?
From
You are telling correct.
subcutaneous tissue till the bone.
Skin. Dermis to, okay?
Yeah.
Periosteum.
Periosteum.
So, what type of incision you give for phelon?
Longitudinal incision.
Longitudinal.
Why longitudinal?
So as to open all the space.
To open all the pockets. Okay, good. That's why you should not give transverse incision. And while giving incision, what you have to take care?
Neurovascular.
Yeah, nerve should not be injured. Right. Okay, what is the common cause for this hand infection? History. What is the common cause? What history the
Usually, it will be some kind of puncture injury or
yes.
Minor
Yes.
trauma.
It is a
Trauma to
minor puncture injury.
Injury.
Yes,
puncture injury.
correct. What is the commonest abscess you see in the hand?
Paronychia. Phelon.
Oh, paronychia. What is the
Good.
treatment for it?
Incision and drainage, ma'am.
Incision and drainage.
So, sometimes you have to remove a little nail also,
Wedge
depending upon
excision.
the extent, site. Okay? Okay. So, will you treat every time the surgical way the abscesses, or you will do the conservative treatment also?
We will try conservative, ma'am. If luck.
What is the conservative treatment?
Start
Be
them on some
fast.
antibiotics and wait for at least on 2 days. If it progresses, then definitely IND. If
And
not, then we can
fluctuation.
continue with if fluctuation is there, then IND is.
Yes. So, conservative treatment consists antibiotics, elevation,
Okay.
painkiller, okay?
Yes.
So, and observe after 24 hours. You have to wait only 24 hours, not beyond that. Okay? And intervene. If you don't, if you neglect the acute abscess, in which areas, where is the chance of extending into palm or into the forearm? What are they? Which fingers mainly?
Little finger and thumb.
Little finger and
Yeah,
thumb.
why? Why?
Because of the
Because
bursa.
Because of bursa connection, sir.
What are they called?
Radial and ulnar
Name.
bursa.
Radial and ulnar
Ulnar
bursa.
bursa.
Yeah, correct. And you told thenar space abscess and mid palmar space abscess, isn't it? So, are they superficial or deep?
Deep.
Deep abscesses, isn't it? So,
Yes.
can anybody tell these importance of these spaces? Are they visible normally?
No, ma'am,
Can
they
you
are
make out that?
No, ma'am, they are potential spaces.
Yeah, they are potential
They are deep to
spaces.
the tendons.
Yes. Which one is deep to the tendon?
Mid-palmar
The
space.
spaces.
Yes. Mid-palmar space is deep to
Deep
the
to
flexor tendons, right? What about the thenar space? Thenar space?
They are also deep to the flexor tendons of the finger, index finger.
So boundaries, can you tell? Then you will be better clear. It will be clear.
anteriorly flexor tendons.
Yes. Flexor tendons will not be there in that because they are more in the
Anteriorly-
mid-palmar space, isn't it? There is a septum between the mid-palmar space and thenar space. Which muscle is most is there in the thenar space?
Adductor
Adductor
pollicis.
pollicis.
Adductor pollicis. Okay. So, which abscess will spread into the dorsum?
Thinner.
Yes. Okay. So the thenar space abscess can spread along with the adductor pollicis and go into the web space, first web space into dorsum. Okay.
Dorsum.
So in the same way, the palmar space also, mid-palmar space, they go into the web spaces and go into the dorsum. So that is the reason it is called cholesterol abscess, right? And this, it can go through the interosseous spaces also into the dorsum. So it depends the abscess size and the pressure, right? Next, common cause for the hand infection. What is the organism?
Staph.
Staphylococcus aureus.
Staph
Pardon?
Staph aureus.
Staph
Streptococcus.
aureus or
Streptococcus.
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 Ecanella.
And Canella cordens.
That's for
Which
human, right?
type of injury it will be?
Human bite.
Yeah, sir has told it is a very dangerous type. When animal bite, human bite, dog bite, cat bite, which is more dangerous?
Human bite.
Human bite.
Next dangerous?
Cat.
Yeah. So order human, cat and the dog. Okay?
Okay.
Yeah.
Human bite చాలా dangerous.
ఎనరోబిక్ ఉంటాయి కదా ప్లస్ ఒకటి జాయింట్ లోకి వెళ్ళిపోయినా క్లోజ్ అయిపోతుంది ఇన్ఫెక్షన్
From my side, almost all.
రాదు
What is the important sign which will be missing in when acute to chronic?
Pain on passive
Pain.
abstinence.
Pain will not be there. Correct. So with the lecture, the questions what I could ask, I asked. Anyone would like to ask any questions to Srikant sir? You can ask Srikant sir. Srikant sir, would you like to ask anything more?
No, I don't need to ask anything, but if they have a doubt, they can ask us.
Yes, sir. Yes, sir.
Please
I think I have.
feel free.
Yeah.
Please feel free.
Please, you please come forward. Anything is required. Sir, how long you would give the treatment? How long you will have to give this drainage and antibiotics?
When you have a suppurative tenosynovitis that has come to you early, it is
Sir.
expected that at least for 72 hours, the irrigation has to be continued.
Okay.
And the point that I wanted to make is whenever you are using antibiotics or you are using irrigation, then you have to follow the signs and symptoms to understand whether it is getting better or not.
Yes,
And the
sir.
hand, the only thing that can tell you it is getting better is resolution of edema. And second is the pain and the tenderness will decrease.
Hmm.
So you have to look for these two clinical things. The patient may not be febrile because it is at the terminal end of the hand. So the main thing is whether the pain comes down, the tenderness comes down, and the edema resolves. Typically, when the edema resolves, you will see that there will be a crinkling of the skin. That means the infection is under control. If not, something is wrong. Either you have to change the antibiotic, continue the irrigation for a longer time, or you may have to formally drain it. But
Is
like
this
Madam said, why is pulse space infection unique is because of the tight fibrous septa. It is, if you delay it, you may lose the fingertip.
yes, sir.
In the sense that fluctuation is very late to appear. So you do not go by the sign of fluctuation for allowing drainage. You just have to decide whether after having started antibiotics, the pain and the tenderness has come down or not. If the patient says he has slept at night, that means he is getting better. If he says, no, I am still not able to sleep in the night, not more than 24 to 48 hours should pass before you should take the decision to drain it. Otherwise, if you have an untreated abscess in the terminal pulp, it is also possible to have an osteomyelitis of the entire distal phalanx.
Yes, sir. Yes. Sir, after draining and putting these things, is it recommended to give the crib bandage?
I would prefer that crepe bandage is not applied till we are sure that there is some uh, crinkling of the skin, which means the infection is under control. Otherwise, it is always better
Elevation.
to rely on hand elevation to control the
Elevation.
edema.
Yes.
And
So at least some 4-5 days better after putting the antibiotics and elevation, we can advise, sir.
yes,
So for tuberculosis, we have to give the same treatment for 6 months.
yeah, in a tuberculosis infection, I think now because you have these 4-drug regimens, it is not necessary to continue for 1 year unless you have something like a drug-resistant tuberculosis or you have atypical mycobacterial infection. We are fortunate that we have a infectious disease unit who decides what kind of treatment needs to be done because you get time
Yes, sir.
to take a consult to decide what is the best thing. And we go only by the biopsy report. Sometimes, even if cultures are negative, and you find the patient has got a caseating or a non-caseating granuloma on the biopsy, even that may be a reason to start the patient on anti-tubercular treatment. And like Dr. Umar said, if you have a non-caseating granuloma, that could be diagnostic of sarcoidosis also, for which medical treatment is available.
Yes, sir.
So biopsy becomes extremely important in any presentation which is chronic.
Yes. Culture
Also,
and
sometimes
sensitivity and biopsy.
also sometimes we even neglect the fungal infections
Yeah.
in the hand, especially in the diabetics. They develop
That's
fungal
why sir
infection
told.
in the webs. Yeah, webs. So they are to be taken control, and they get secondarily infected later on. Then there occurs the mixed infection, fungal as well as the bacterial.
Yes, sir. Yeah.
We see fungal infection even in transplant recipients.
Yes, yes, yes.
There's a lot of renal transplant going on.
Wherever there is immunosuppressive drugs given or diseases, definitely we should keep in mind about fungal infections, isn't it, sir?
And like I said, it also depends on occupation. People who
Yeah.
work in the fields,
Ah.
if they present with a chronic infection, it is likely to be A fungal infection,
A fungal
actinomycosis, nocardia, Madurella mycetoma, and things like
Yes,
that.
the spirotrichosis,
Yes.
what was that called? Yes,
Yeah.
that can happen.
Gardner's disease.
Spirotrichosis is a fungal infection from the soils, plants that rose thorn and all that, what were being taught, no, sir? Sporotrichosis. And people
Sir,
in those fisheries and all that, they have that infection, especially in their webs, due to the chronic immersion of their hands in the water, which is almost polluted. They can have infections on the hands.
sir, one more thing I would like to ask you. After this control of infection, I think it is very essential for the physiotherapy.
Yes.
Otherwise, again,
Treatment.
the movement restriction or deformity will develop.
See, I wanted to add this point here. You could probably
Yes.
do a pulp infection on an OP basis, but anything
Yeah.
more than that, it's always better to admit.
Yes.
And like Dr. Lakshmi said, once you are sure that the infection is under control, you have to start some kind of therapy before you discharge the patient. You are not permitted therapy during the presence of the infection because the infection may spread because of movements. But once you are sure clinically patient has improved, swelling has come down, fever has come down, tenderness has come down, you should start the therapy which you want to give before you discharge the patient. Otherwise, the entire thing will get stuck.
Yes, sir.
For some time, we were mostly seeing the diabetic feet. But for some time, we are seeing a lot of diabetic hands. This time we have diabetic hand plus he has a very severe cellulitis, fulminating cellulitis of whole
Yeah.
of the upper limb. Very sick patient he presented in the casualty. So diabetic hands are also becoming very common. Uncontrolled sugars are there. So there
Yeah.
is really trivial trauma. So there is a very bad hand. As the it happened with the foot, the same happens
Yes.
with the hand.
Yeah, Dr. Umar, you're right, absolutely.
Yes, sir.
Diabetic patients, one, they can be because they may have some kind of paronychia, chronic,
Yes,
Yeah.
sir.
which has got
Yes.
an acute exacerbation.
Yes.
Second, they may not be sensate. So if they have an accidental injury of trivial something, that will introduce the
Unnoticed.
infection.
Unnoticed it goes.
Unnoticed infection. Third, there may be a compromised vascularity overall, which is why when they present late, they may have necrosis, which may lead to an amputation also.
Yes,
Yes,
sir.
sir.
Yes,
Yes,
sir.
sir.
Yes, sir.
We are seeing many cases. We are seeing now we were previously we used to do it very less, maybe in a month, 2 months, one. But we are not frequently getting.
Yeah.
I think weekly we are getting one hand, one arm, and diabetic feet are very common. But arms also we are getting.
Always we should exclude and keep in mind when there is hand infection regarding diabetes, sir.
Yeah, yeah. Always, always. It
Always.
should be kept. Yes, yes, yes.
Dr. Santa Kumar, would you like to say anything, contribute?
That is there.
Yeah, yeah. Dr. Shanta Kumar.
Madam.
Would you like to share any of your experiences or?
Nothing. Only for the postgraduate, just I want to tell that question came now about creep bandage, use of creep bandage. Actually, in any conditions of the hand infections, I think creep bandage is the one which should avoid unless it is totally subsided. One thing. Second thing, the main thing is hand elevation was sir told, and glycerin myself dressings with antibiotic care. There is no role of creep bandage in the upper limb, the hand infection especially.
Yes. Infection, we should not use the crepe bandage.
Yeah, that is the actually. Yeah.
Yes.
Yeah. Thanks.
I
Rest all
want
I
to
think I
make it
discussed.
very printed in the minds of PGs. That's why I asked.
Yeah, okay. Yeah.
This session was very enlightening and a very common condition we discussed today.
Yeah,
We
yeah,
see on
yeah.
and off every
Actually,
day, every
the
other day.
problem is it should be diagnosed and treated well so that the complications will be less. So,
Madam, one point I would like to add.
Sir.
I showed the diagram of, I want the PGs to understand because they're going to become practitioners in the future.
Yeah.
It is very simple to make a collar and cuff sling because the OT worker can also do it.
Yes,
But
yes,
generally speaking, it is not a good method for hand elevation. So the two methods that I suggested, the triangular bandage is very simple.
Yeah.
It's very simple. You don't need anything special. But nowadays, because those arm pouch slings are available very easily, you
Yes,
should
sir.
probably use an arm pouch and then suspend it from an IV stand. That way, you don't have a constricting effect at the wrist and you don't have an acute flexion at the cubital fossa, which may increase the edema rather than decreasing it.
Yes, sir. Nowadays, no, rarely we are using this cuff and collars, sir.
Yeah.
So, arm slings are available everywhere.
Yes.
So, most of them are using that only. But it is a very valid point to be considered. Even if arm sling is not available, that triangular pouch method can be used. Dr. Venkatratnam, B. Venkatratnam Garu, think he is not there. I think the time is also over. Sudhakar sir?
Yeah, Lakshmi.
Would you like to contribute?
Though I missed the presentation of Dr. Srikanth, I just have one last question. I mean, we were discussing about the chronic paronychia of the fingers and all, particularly in the women who work a lot with water. And most of the time, we see the chronic paronychia with the receding nail fold and exposed lusterless nail. What do you normally do? Most probably it is onychomycosis, but very rarely can a fungus be isolated from there. So normally, I just want to ask Srikanth as to what his experience and treatment that we can offer, because
Sir, I have seen only 2 cases of onychomycosis with a completely deformed nail. In one case, we removed the nail, sent it for a biopsy along with scrapings from the nail bed, and we prescribed the patient only topical antifungals. Even though the fungal culture was negative, ultimately the nail grew back.
Okay.
The other condition which we recently saw, a brother of the CT surgeon in our hospital, diabetic, he was also being diagnosed with paronychia, but then he had exquisite pain. And for some reason, we had a doubt. We got an X ray done, and it turned out to be a glomus tumor.
Oh.
So, I'm not sure whether I mean anything by saying this, but it's best to keep that in mind.
Yeah.
Because the presentation would be nearly similar. Severe pain for a particular duration, and it happened to be under the nail, so it was excruciatingly painful. But because of the history of diabetes and some changes in the nail, a diagnosis of paronychia had been made. But because we got an X-ray done, and I also think that once you have a hand infection, it's better to get an X-ray done because in some of these cases may be associated with foreign bodies or thorn prick or pin prick or whatever.
Yeah.
So it may be valid to do an X-ray in a patient who has got an infection.
Yeah. Actually,
Sir,
I am I'm basically referring to the chronic paronychia with the nail getting exposed, the proximal part of the nail, and the nail fold receding. I mean, many people come to the plastic surgeon because that is deformed and they're having some chronic pain. Like you said, probably the antifungal drops can be prescribed to them.
The one that we used in that particular case was nystatin drops or clotrimazole, because systemically it's not going to work antifungals, but the local certainly helps to an extent. In addition, the instruction, the patient should not get his finger wet for at least 3 months. Or
Yeah.
even if he gets it wet, he should take care that he wipes it and
Yeah.
keeps it as dry as possible. In the interim, that the nail has to grow back.
Yeah. Yeah.
Sir, I think
Thank
they
you.
will give oral griseofulvin also,
Mhm.
along with the local antifungal drops.
I have not tried it, but personally, I'm
But
not.
dermatologists, they recommend
Okay.
tablet griseofulvin,
Okay.
antifungal. Okay.
Okay.
There's a raised hand, Dr. Ashok Kumar. They want to share. Ashok Kumar?
Yes, sir. Please
Ma'am,
unmute yourself.
Please unmute and
ma'am, actually,
there.
when you asked which of the PGs are there, this time he raised it. After that, he is not removed
Okay,
actually.
okay.
Okay.
They
Still is
might, he
pending.
might have answered. Right. I think we came to the end of this wonderful interactive session. I think everybody enjoyed. And I invite Janaki Raman, who sponsored this Zoom platform for us today. Dr. Mr. Janakiram?
Yes, madam. Yes,
Yeah.
madam. Thank you, madam. Actually, first of all, thank you very much to you actually giving this opportunity to us. Actually, this being this wonderful educational program sponsoring. This is not a big actually to us. At the same time, we also learning, madam. Actually, since actually Harshita supposed to attend this program, since she is the medical emergency, I attended. Actually, year after, I am only going to attend this program. Really. Taking the lecture from Srikanth sir, I learned many things actually because it will be really helpful for us when I'm meeting the plastic surgeon across the South region. That will be really helpful for us. Actually, myself, Janaki Rama, working as a regional manager in Urgo Medical India. Actually, we are the globally one of the leading company when it's come for the advanced wound care products. We have been supplying for across all over India for many of the medical service corporation, including Telangana Medical Service Corporation also. The product and everything, when we are coming, we will be meeting in person actually. So beyond that, I don't want to spend more time actually. Really helpful, madam. Thank you so much for giving opportunity to us.
Thank
Okay.
you. Thank you, everyone.
Thank you. Thank you.
Good night.
Umarji.
Bye-bye.
Good
Good
night.
night.
Bye-bye, ma'am. Good night, everyone.
Thank you,
Bye-bye, sir.
Srikanth sir.
Bye-bye.
Thank you.
Bye, sir.
Bye-bye, sir. Bye-bye.
Thank you.
Can I end the meeting, madam?
Yeah.
Yeah, please, please.
Yes.
Bye.